welcome everyone. So as you log on to the Zoom platform and you have audio, please enter into chat, locate your chat button and enter into chat your facility name, your name, the name of any others in the room with you, and the state where you're located. And we will begin in less than a minute. So meanwhile, let's see what's in chat. My teammate Kristen will be monitoring the chat. So please enter in chat your facility name, your name, the name of any others in the room with you, and the state in which you're located. The chat feature will be something we'll use throughout this presentation. So let's get used to entering in chat. Introduce yourselves. Okay, so I have 12 noon. I'm in Illinois Central Time, so we will begin now. And as others come in, we will continue to use the chat feature. So welcome. My name is Nell Griffin, and I will begin our presentation. My co-presenter is my teammate, Roseanne Milovich. We affectionately refer to her as Ro. And welcome to our session today, which is titled Behavior Health Infection Prevention, Overcoming Challenges Together. Now, as always, if you haven't done so, please do register for the upcoming Nursing Home Quality Essential Spotlights. Our focus is always on infection prevention. You can scan the code to register, or you can go to our website, QIN-QIO. We meet every Tuesday and Thursday for 30 minutes at 11 a.m. Mountain Time and 12 noon Central Time. And every topic is designed to support you in your infection prevention efforts. We also have available that you can access at your own time the nursing home on Intelligence website. We have the vaccine toolkit, which is designed to help you with to support your efforts to confirm that residents and staff are making their decisions about vaccines based on accurate information. And that's our goal. We want to educate them and just make sure they make their decision based on accurate information. The toolkit and our vaccine hub is a resource to help you with the language and the tools to confirm that you are relaying them, doing the education based on correct information, accurate information, and evidence-based information. So do use those two links on this, and you will get a copy of these slides, and you can use those links to download resources to help you. So today we're going to talk about behavior health and infection prevention, overcoming those challenges together. Emphasis on the word together. This will be collaborative, interactive. We do want you to unmute. We want you to share. We want you to use the chat feature. So emphasis on together. Today, we're going to talk about that relationship between behavior health and infection prevention. We're going to share, that's what we're going to share and collaborate on those challenges that we experience and what you know works for you when you're dealing with behavioral challenges and infection prevention. The two can be challenging to bridge together. So we're going to share on that, and we're going to identify some actual evidence-based behavior and de-escalation interventions. We're going to talk about techniques today. So everything we do in healthcare, education, documentation, huge elements. Everything we do, we have to educate on, we have to document. Now, the challenges come when we have to really apply the education. Education is not just giving information that you do nothing with. We want you to actually implement it, and that how piece can be very challenging. And that's what we're going to talk about and share, how we do that when we're talking about infection prevention and behavior health. Now, just on the surface, they seem to be very distinctly different, but infection prevention is something everyone is involved in. Now, when you have behavior health also in the picture, now that provides some unique challenges that we want to navigate. So everything involves education, documentation, and the application of all of these is part of that documentation. But infection prevention and behavior health, we're going to mirror those two in this presentation together. So let's be on the same mental model. When we're talking about behavior health, what are we talking about? We're talking about those overall mental stresses, the mental conditions, those thoughts of suicide, and those behaviors that evolve from that, and substance abuse and those behaviors that evolve from that. what do we do? There are definite multiple layers with all of these. It involves your social drivers. It involves the environment, the work environment, what you learn, experiences. So all of that comes into play. And every individual person's experiences are unique with that. So how do we standardize these practices and these behaviors when there is so much uniqueness for each individual? That's what we're going to talk about. But those are the behaviors that still come into play, because for infection prevention, it involves everyone. Regardless of what your medical status, mental status, you're still involved in infection prevention. How do we do that? So we want to stop the spread of those communicable diseases by our behaviors, by our choices. And those are standardized things that we can put in place because everyone's involved in infection prevention. So the standards that we have in place, those external, this is the first wave, is standard precautions, hand hygiene, PPE, respiratory etiquettes, your social environment, social distancing, cleaning and disinfecting the area, how we handle laundry, how we handle injectables. All of this is the standard precautions that everyone who's involved in healthcare, and that's all of us, should know. And we have to train on them. There are specialized techniques. These are the trainings you put in place, and everybody who enters your facility should have these trainings, right? Now, also, the next layer, the standard precautions we just talked about, those are external. Now, we also have the internal, which is the vaccinations. They help if you do become infected, help your body fight. This is the second line of defense. Now, also with this, and you'll have access to this. Hopefully everybody is informed of this, but the surveyors will be taking a deeper dive into how we document and how we actually complete these practices beyond education, how you implement, how are you monitoring, what data you're using. They're going to take a little deeper dive in that. And that memo gives you resources for that. But our vaccinations is still one of our resources and one of our strategies to really help with this. That's the second way. You have to educate, and that's part of what the vaccine hub and what our toolkit helps with. We have to provide the education, and it's specific. What are the benefits, the side effects, and we must offer the COVID-19 vaccine to everyone. But uniquely to this is if we have behavior health. That's a whole layer of complications and challenges that come into play. How do we do that? You should be documenting the behavior health, what you have observed for the behavior health residents in their record. And then for any challenge, we have to have a solution. So this is what we're going to talk about next. So based on what we know with behavior health and the COVID vaccination, let's mirror those because that's the second way, and your infection prevention practices. How do we do that for some of these residents that have these challenges? So think about this as we go through. Just think about this. Keep this in mind. Are there actions and documentation considerations for residents that you know have behavioral health diagnoses? We're going to talk about that. We want to share on that. So just as a reminder, there are trainings we have to have in place. You are required to train on communication, and that also for those residents who have behavioral health. How does direct care staff work with them? What do we know about that? That's a special layer of training. Infection prevention and control, mandatory. We have to share that with everyone. Behavioral health, we have to have training on that. Now, another layer is trauma-informed care. We have to know if our residents have some sort of trauma so we can navigate that. That also has a behavioral health component to it. Now, for nursing homes, caring for residents who have behavioral health considerations that's a unique training and compliance challenges. And now we're going to talk about that. So I'm going to hand it off to my teammate, Ro, and she's going to take it from here. Now we're going to collaborate. So Ro.
All right. Can you see that okay?
Looks good.
We can.
Okay, perfect. All right. Hello, everyone, and thank you for joining Nell and I today. So I'm going to keep on chat. Like Nell said, we're going to do this together. So feel free to unmute, put something in chat, but think of this as kind of a meeting that we're all just talking and brainstorming. But let's talk about these three images that you see here. When I looked at them, I immediately remembered a situation that I've been in. We most likely all have encountered a situation with a resident, especially now that facilities are admitting younger residents. So again, if you're comfortable, unmute. If you rather put in chat, that works too. But I want you to think, imagine you're talking to these residents and educating them on wearing a mask or washing their hands, educating on the importance of hand hygiene. What do you think is going on under the surface? We see this and I see, anger, anxiety, maybe indifference, getting frustrated, irritated. But tell me what you think. What's your interpretation of what's going on underneath? Anyone want to mute? Remember, we're just talking. What's really going on? And if you don't feel comfortable, that's totally okay. I want to give you some scenarios. Julie, frustration of the resident. Yes. And I can give you some more information, and that might be a tricky question, but I want to give you some scenarios and background or histories on these fictional residents. So let's just pretend that we have Mr. Jim here on the left, and then we have Mr. Thomas here in the middle and Miss Jane here on the right. And on the slide I listed some potential stressors or situations that might trigger these residents. So in terms of when internally I'm thinking, is it a trauma response? Are they getting frustrated and angry? Is that a trauma response? That's something that's happening internally. So Mr. Jim over here, he has a diagnosis of schizophrenia and alcohol dependence uncomplicated, and he was homeless prior to admission. So again, these are fictional. These are just some made up histories that probably sound very familiar. Mr. Thomas has a bipolar disorder diagnosis and in a manic phase right now. And also he's a veteran with a PTSD diagnosis. And then Miss Jane here, she has mild cognitive impairment, the depressive disorder, and a diagnosis of PTSD. She's experienced a lot of domestic abuse in her history. So based on what the resident is experiencing, what's happening under the surface, that is going to influence how the resident reacts or interprets what you're communicating to them. So maybe you're educating, maybe you're asking them to put their mask on, but what's going on under the surface, that is going to filter and how they're interpreting what you're communicating, what you're educating them on. So let's move into the mental health crisis in older adults. And this information is probably not a surprise to you, but serious mental illness, substance use disorders, anxiety, and depression are at a crisis level among older adults, especially in long-term care. And 75% of long-term care residents have one or more mental health diagnoses. And the most prevalent are depression, anxiety, serious mental illness. And you might see this reflected in your facility assessment. And then social isolation and loneliness during COVID-19 have worsened this crisis, and mental health disorders increase the risk of severe COVID-19 outcomes. So let's talk about that a bit more. So again, please unmute. Don't worry about wrong answers. We're just here to collaborate and have some ideas for each other. So scenario 1. So Linda is COVID-19 positive and refusing to wear a mask and follow isolation protocol. This is probably all too familiar. So please unmute and share, how have you approached this situation like this? And not all residents are the same. You're from facilities that have different populations, different ages, different backgrounds. So tell me how you've approached this situation, or how have you seen another staff member approach this situation?
The residents probably feeling overwhelmed or feeling like they're losing control.
Absolutely. I didn't see who, is that Audra? Thank you. And how have you, knowing that, what has been your intervention? Or has that been a challenge for you in your facility?
Focusing on what the resident does have control over.
Yes.
What do they like to enjoy?
Absolutely. So I think that was Jamie. It sounds like instead of focusing on the behavior, you focused on something that the resident had control, something that they enjoyed. Did I hear you right?
Yes.
Awesome. Great. Love that. I saw a few people unmute. Do you want to go ahead and share?
We had this is my name is Angie. We had this problem in our dementia unit with many people, and COVID did spread to a lot of people, and we did our best to try to re-educate and keep them calm and try to have them go back to their room, or we would have them sit in a different area away from other people. Eventually and staff were wearing masks. Eventually we just, I think, realized we can only do what we can do, and we try our best and try to limit that spread to the other wings, that besides this locked unit. So it is, I don't think there is a really good solution with this population other than you just have to, have compassion and just do your best and realize there's going to be spread. But if anybody has a real, I would love if we could have had negative airflow in rooms, but we don't. We can't open our windows because it's negative a million, and we just do the best we can. And I think the outcomes from the people, they were not very ill, so that was different than, I guess, in years past when they had COVID. So that kind of kept us a little more positive too.
Mm-hmm.
That's about all.
Yeah, Angie, you said so many important points. I just wanted to highlight one of the things you said, and you said that you focused on what you could control. And sometimes that's the absolute best that you can do, is you focus and you put your energy into what you can control. So thank you for that, Angie. I have another scenario, probably very familiar. John consistently displays poor hygiene. He refuses to wash his hands before meals and throughout the day. Anyone have anything they want to share based on what, this experience in your facility?
Depends on what the diagnosis are. If the resident has dementia, sometimes I've used, hey, my hands are dirty, can you help me wash them? And so that in turn will have them, their hands under the water, they're washing mine at the same time they're washing theirs. So it kind of depends on what their prior diagnosis are.
Yep, that's a great one, Jamie. Thank you for sharing that. And I see hand wipes, hand him a washcloth to wash hands. Sure, yeah, you adjusted, you modified based on the resident's need. That's, you focused on what, you got creative and modified your intervention. So that was great. Thank you for sharing those ideas. So I shared Maslow's hierarchy of needs in a past session, but I applied it to the workplace safety for staff, but the hierarchy can be applied to resident needs as well. And if you had an introduction to psychology, you most likely heard of Maslow's hierarchy of needs, and it's a 5-tier model of what humans need, shown here by this pyramid right here. And at the lowest level, right here, we need our basic needs met, which is to feel safe. So do residents feel safe? Think about your personal home. When you go home, that's your safe place. That's what needs to be created for your residents at your facility, and which is their home and their community. So Maslow suggested that basic survival needs must be met before an individual can focus on fulfilling these higher level needs as you go up the pyramid. And as you go up, meeting the needs becomes more challenging. So if a resident is dealing with a history of trauma, mental illness, cognitive issues, meeting the safety needs might be difficult, but understanding where the resident is can help your approach and gain a new perspective, just like everyone that just shared, which was wonderful. So let's talk about some behavioral and de-escalation interventions. First, recognize that every situation is unique, and I wish I can give you a list of helpful strategies to use in every situation, but every resident is different with different behavioral and emotional needs, and everyone has a different approach. So let's focus on the approach and the de-escalation interventions. So first, identify early warning signs. Learn them for your residents. For example, facial expressions, pacing, tone. Intervene before the situation escalates, or step away if you're not sure how to address it. And then practice active listening. Pause and listen. Sometimes we feel pressure to say something right away, or we want to correct the behavior, but just listen. A lot of the time, that's what we want. That's what we're looking for, is just to be heard. Also, practice staying calm and composed. And this one can be tough, especially if you feel triggered by aggressive behavior. If you're able to remain calm, that's going to influence your own reaction, your behavior, your tone of voice, and ability to think what intervention would work here and help this resident. Empathy statements. They are so powerful. When you learn how to reflect what someone is feeling, they feel heard. And you're feeling, for example, you're feeling frustrated that I'm always asking you to put your mask on. Yeah, I am frustrated. Thank you for acknowledging that. Shared decision making. Remember that residents and their family members, they're part of the team. They're part of the care team. They're not just the person that you're taking care of. They're part of the team. Practice offering options and choices. That gives someone a sense of control. I think Jamie brought that up. Acknowledge and validate feelings. Just like empathy, when you're validated, it feels good. For example, this is frustrating. Always hearing from so many staff tell you the same thing. Feels good. Identify potential triggers and care plan them. If you know what is going to trigger a resident, share that information with the team and care plan it and communicate it so everyone knows in your facility what to avoid. And then create a safe, supportive environment. Respect personal space. And this aligns with Maslow's hierarchy of needs. Ensure there's a good amount of space between you and the resident. Hovering over a wheelchair might not feel safe for a resident, especially if they have some past trauma. Okay, so I did choose this graphic deliberately because sometimes when you're approaching a resident, it might feel like you're rolling a dice and you don't know exactly what reaction you're going to get that day. So you can control that part, but you can't control that part, but you can control how you approach and react. So let's keep on focusing on that. So engage family and friends. Sometimes when you ask direct questions from families, you can get a lot of insight, a lot of information. Asking them their likes, their dislikes, what did they do when they were frustrated at home? That's really important to get that information. Utilize positive nonverbal cues. This is very important because most of our communication is nonverbal. Shaking your head up and down, just like Nell is. I know she's listening because she is shaking her head up and down. And it says she's listening to me and it feels good. I know that. Leaning in, undivided attention, not crossing your arms, calm facial expression, relax your face, open posture, smiling and making eye contact, especially if the resident has a hearing deficit. Reapproach, wait 30 minutes and then come back. Really important. I'm sure you do that a lot, especially when you're offering showers and bath time. Provide reassurance. If a resident is experiencing anxiety or fear, feeling unsafe, reassurance is really helpful. Saying, it's okay, don't worry, it's not a biggie. One that I used a lot, especially working with the population with substance use and major mental illness, is no judgment. I would preface my sentences with no judgment because often residents can feel you're judging them. So their defenses go up, and then they can get more frustrated and verbally aggressive. So I would just say, hey, no judgment. That's how I'd preface my sentences. Empower resident decision making. Collaborate as a team. Find that one staff that has rapport with the resident, and have them talk to the resident. And a lot of the time we're hearing, and when we're conducting these root cause analysis, communication is often the breakdown. So in a process, so making sure that you're really communicating and collaborating as a team. Redirection, very, very useful. And incorporate appropriate humor. We all love to laugh. It's very powerful to use humor. And then the last, develop individualized care plans. Take credit for all the work you're doing. I know there's a lot of the time you're providing these interventions, these great interventions, but they're not documented. So making sure you're doing that. I know we're getting close to time, but I just wanted to see if anyone has any successes, any challenges, anything that's worked for you, just based on what we've talked to you about, that you'd like to share. Or if you're having a challenge and need some help, this is a great time. You have all these peers on the call that can help out if you have anything. And I'm looking and I don't see anyone unmuting. All right, then I will keep going. So, creating an enhanced behavioral health program to meet your facility needs. First, I want to emphasize staff training. I now brought this up. You might have a lot of new staff that don't have the tools to work with a behavioral health population. So this is very important. So I really encourage you to become familiar with the behavioral and emotional status critical element pathway, and also section F483.40 in the updated CMS memo that now mentioned, and we did put in chat. This is something your leadership team can review together, and please make sure your social services department has a copy of this. Often your director and social workers don't know what surveyors are looking for, so this is incredibly helpful. Resident council, this is a really underutilized resource and really great way to talk to your residents and really solicit their feedback that would be helpful for them. Behavior monitoring and individualized care plans. I have these all listed here that you can come back to. We're going to share these slides on Friday, but these are all great interventions for you to implement to really develop your behavioral health program. Trauma-informed approach, that's part of that CMS memo, really important. I'm going to share some resources with you. Huddles, again, underutilized resource. Health literacy, and conducting root cause analysis, incredibly important, getting down to the root cause. Often you're documenting refused despite education, non-compliant with care. But what's the root cause? Really looking to see why and what is happening. And team steps program. This is really a way to help with communication and teamwork. And Kristen's going to put that link in chat for you. I have some resources here for you. We're going to send these out Friday, but SAMHSA has great resources for psychosocial interventions and also for trauma-informed care. They also have great flyers. You can print these out. You can use them in training, tips to manage challenging situations, the do and don'ts in nonverbal communication, and the comfort menu. And then they have a de-escalation toolkit. So if you have residents that are have some challenging situations, this is great to share with your staff. So what's next? Share this information with your QAA committee. This is something your social services, your activities, your infection preventionists can really collaborate on and discuss this relationship and really develop a behavioral health training program based on the updated surveyor guidance now mentioned on slide 10. Then select your strategies to implement. You need to schedule your trainings, look at your facility assessments, and really determine what trainings your staff need. If you need a facility assessment, we have one here for you. Kristen's going to put it in the chat. This is not mandated. This is just a template for you to use. And you can always look at this template and compare to your own. So any questions? Anything that Nell and I can help? I'm going to keep on going. I don't see anything, but please stay on and complete our anonymous. It's a 5-question assessment. And really quick, but we love the feedback. So we appreciate you staying on and just clicking continue and it'll take you to the questions. And reach out to us if you do have any questions. Follow us on social media for updates. And then please don't miss out on these upcoming sessions. On Thursday, we have a session on the EVP. Next week, Kristen's going to review some IP resources for you. And then on the 27th, join us for some communication strategies. But that's it for Nell and I. We did it now. We got it right on time. But we thank you so much for joining us today. It was great to see everyone, and we really appreciate everything you do. So we hope you have a great day.
Okay, bye everyone. Hopefully you'll download these slides, and our goal is to help you not just do something, but do the right thing for each of your individual residents, and these resources should help you. So thank you for joining us, everyone. Bye-bye.
Thank you.